eminent faculty members and participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Farooq Shah from Abu Dhabi, our chief guest for the day, Dr. Sujata Sharma from Mumbai, all discussants and participants to this virtual symposium on managing conception and pregnancy in thalassemia syndromes. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the edges of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a very passionate and dynamic hematologist and bone marrow transplant physician from Surat in western part of India. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Sumit. Well, very good morning to all of you, and good afternoon, good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Farooq Shah from Abu Dhabi, and she's going to lecture us on managing conception and pregnancy in thalassemia syndromes. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and Team Zydus, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Professor Dr. Sujata Sharma from Mumbai, our guest speaker for the day, Dr. Farooq Shah from Abu Dhabi, all our discussants who are themselves very eminent pediatric as well as adult hematologists, and you participants for sparing your Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give you a flavor of our next weekend activities. Next Saturday, that is 10th of August 2024 from 7 p.m. Indian Standard Time and 9:30 a.m. Eastern Time, your Dr. Amy Shapiro from US is speaking to us on the use of prophylaxis in the treatment of rare bleeding disorders. And the following day, that is 11th of August 2024 Sunday from 11:30 a.m. Indian Standard Time, your Dr. Reena Nair from Tata Medical Center, Kolkata, speaking to us on bispecific antibodies in lymphoma. Let me introduce our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Aditi Shah Kaskar from HCG Hospital, Borivali, Dr. Akash Khandelwal from Action Cancer Hospital, New Delhi, Dr. Anju Bharti from Banaras Hindu University, Varanasi, Colonel Dr. Ashok Meshram from Command Hospital, Kolkata, Dr. Ashraful Haq Chaudhary from Dhaka Medical College Hospital, Dhaka, Bangladesh, Dr. Ashutosh Panigrahi from AIIMS Bhubaneswar, Dr. Avinash Kumar Singh from Paras HMRI Hospital and Patna Hematology Clinic, Patna, Bihar, Dr. Chandima from Colombo, Sri Lanka, Dr. Chandrasekhar Bandi from Mahatma Gandhi Cancer Hospital and Research Institute, Vizag, Dr. Deep Jyoti Pusti from Institute of Medical Science and Some Hospital, Cuttack, Dr. Hamza Dalal from Fortis Hospital, Mulund, Mumbai, Group Captain Dr. Harshit Khurana from Armed Force Medical College, Pune, Dr. Humaira Nazneen from Dhaka Medical College Hospital, Dhaka, Bangladesh, Colonel Dr. Kundan Mishra from Command Hospital, Lucknow, Dr. Lisa Bulsara from Avinash Cancer Clinic, Pune, Dr. Narendra Kumar Chaudhary from AIIMS, Bhopal, Dr. Nikhil Kumar from Fortis Memorial Research Institute, Gurugram, Dr. Nita Radhakrishnan from Postgraduate Institute of Child Health, Noida, Dr. Omkar Khandkar from TN Medical College in BYL Nair Charitable Hospital, Mumbai Central, Mumbai, Dr. Priyanka Samal from IMS and Some Hospital, Bhubaneswar, Dr. Radhika KK from Nizam's Institute of Medical Sciences, Hyderabad, Dr. Rajat Bhattacharya from Apollo Multispeciality Hospital, Kolkata, Dr. Rajesh Patil from Hemocare Hematology Center and Bethany Hospital, Mumbai, Lieutenant Colonel Dr. Ranjit Matthew Varghese from Command Hospital, Pune, Dr. Sandeep Bartake from Bharati Vidyapit Medical College, Pune, Dr. Sitaram Anandram from St. John's Medical College Hospital, Bengaluru, Dr. Shruti Kakkar from Dayanand Medical College and Hospital, Ludhiana, Dr. Subhash Chandra Jha from NGRS Hospital, Patna, Dr. Sukriti Gupta from Artemis Hospital, Gurugram, Dr. Sweta Lunkad from Avinash Cancer Clinic, Pune, Dr. Sweta Shanbag from Father Muller Medical College Hospital, Mangalore, Karnataka, Dr. Yi Mon Ten from North Okkalapa General and Teaching Hospital, Yangon, Myanmar. Now it's time to introduce our special guest for the day, our chief guest, Dr. Sujata Sharma from Mumbai. Dr. Sujata Sharma is Associate Professor in charge, Division of Hematology, Oncology and BMT, Department of Pediatrics at Lokmanya Tilak Municipal Medical College and Hospital, Sain, Mumbai. She has done fellowship in pediatric hematology oncology. She started the first public sector BMT unit in the country at LTMM College and General Hospital along with Dr. Mamta Manglani. She has organized 12 national and regional conferences in pediatric hematology oncology from 2018. She has about 114 publications and presentations in local, regional, national, and international conferences. She has about 84 publications in various national and international journals. Her subject of special interest includes hemoglobinopathies, anti-DT, hemophilia, and pediatric immune thrombocytopenia. It's my privilege to welcome Dr. Sujata Sharma to inaugurate our webinar and give some words of wisdom. Over to you, Professor Dr. Sujata Sharma, ma'am.
Yeah, thank you, Dr. Amit Khurana. And at the outset, I should thank the MHG and Dr. M.B. Agrawal to inviting me as a chief guest on this occasion. There's such a big list of hematologists as a discussion today that itself shows that how interesting the topic is today, and how there are so many issues which are still need to be addressed. Now, to whole pediatric hematology, oncology, and all the adult hematology, I just wanted to say that thalassemia per se is a very, very big group of patients which are very much neglected in most of our communities and need to be addressed now. Previously, thalassemia children were not reaching their age of around not more than 20 to 25 years, at least in India. But now, even in India, the patients are having a lifestyle as like as any other normal child, person in this world. So the thing is, like, it is not so easy for them to pass through this journey, and they have to have a consultation with so many hematologists, oncologists, not oncologists, sorry, the gastroenterologists, infection, and they have to tackle so many endocrine problems to reach to their puberty and to have a normal life and a reproductive life. Now, what I wanted to say, this important to our hematology new aspirants and these specialists, like when you take care of thalassemia, because thalassemia forms a very big chunk of patients. When you take care of thalassemia, you automatically land up being a very good pediatrician and pediatric hematologist also, because you are seeing the patient in totality and you also are in touch with other specialities. So you become known in all our fields. At the same time, you are becoming a very good hematologist. Now, at least in India, now they have diverted these patients more towards the periphery. Like even the district and civil hospitals are now being converted into thalassemia care center. So now the scope of hematologists is now expanded not only to 3-tier cities, but also to 2-tier cities. So I just say that if you are taking care of thalassemias, even at 2-tier cities, apart, because now you feel that the 3-tier cities are getting saturated, but it's going to be a very big help. So as I feel that if you take care of thalassemias, take care of your patients well, you are going to become famous and you are going to do a very good job in your practice. And now today's subject is a very important subject about conception and pregnancy in thalassemia, because now our children or our thalassemic patients are reaching to the age of conception. Like in my own center, we are having 3 such patients who are married to a normal person and conceiving. Like one patient had a problem with multiple abortions. We now prepared her for pregnancy and now she had delivered a child, but her course was very stormy. And that is why I feel this subject has to be addressed properly, as we are now going to see such patients in near future. So I think so we should, anyway, you are welcome, but I shall still welcome Dr. Khurana, Dr. Farooq Shah about this topic of conception and management of pregnancy in thalassemia. So with this wisdom of words, I thank you for inviting, and let us go back to our topic of discussion today.
Thank you, ma'am, for that, such a wonderful, great words and joining us as our chief guest for the day today. Thanks for being there Sunday morning.
Yeah, thank you.
So now it's the time to introduce our guest speaker for the day. We have with us Dr. Farooq Shah from Abu Dhabi. Dr. Farooq Shah is consultant hematologist, Whittington Hospital, NHS, London from 2004. She was also the honorary consultant at University College London Hospitals, London from 2006. She was a member of the Clinical Reference Group for Hemoglobinopathy since 2013. She is current chair of the National Hemoglobinopathy Registry, current chair of the UK Forum on Hemoglobin Disorders. She also sits on the National Hemoglobinopathy Panel, both as an expert and as lead for the NHR. She is also extensively involved in improving clinical care and access to expert care of patients in UK. Today she is with us and she is going to lecture us on managing conception and pregnancy in thalassemia syndromes. Well, thank you so much. Over to you, Dr. Farooq Shah.
Thank you very much for inviting me to speak at this really very esteemed meeting. I'm very honored by the invitation and the fact that, you know, there's such a proactive, engaged group of hematologists, all interested in this very important field. So basically, the management of conception and pregnancy in thalassemia syndromes. This guideline was developed by the British Society of Hematology. It's taken us about 3 to 4 years to get through the whole process. And we've had very, very extensive peer review for these guidelines by the Endocrine Society, the Royal College of Obstetricians and Gynecologists, as well as the final peer review people when the guideline went for publication to the British Society of Hematology Journal. As a consequence of this, the guideline has really had very, very rigorous oversight from a really big multidisciplinary group of people. So these are my disclosures, and I'm going to start off with this picture. This is a picture that is on the thalassemia unit wall at the Whittington Hospital. And this was when having children was a really big aspiration for the thalassemia patients in the late 1990s, early 2000s. And you can see that we were having patients having children successfully in those days, but actually now it has become kind of an expected thing for all patients to be able to get married, have relationships, and then have children. And I'm very pleased to say that many of my patients are now grandparents, having had children in their 20s, 30s, and early 40s, and their children are now having children. So today I'm going to cover the guidelines. Basically, the guidelines are published in the British Journal of Hematology. I am hugely proud of the guidelines because it was a very robust collaboration and I think covers almost all of the key things that you need to be able to deal with when you're supporting a patient through conception and pregnancy. So we start off with optimization of patients. I'll then talk about fertility preservation because this is hugely important for patients. And then conception and the challenges that patients may face around conception, and then what you need to do for your female patients when they are actually pregnant. So why is a guideline so important in this situation? Well, there are many risks for pregnancy, and as our chief guest just said, her patient had a very stormy course during pregnancy, and we know that our patients can develop cardiac problems, they can develop cardiac arrhythmias, they can develop new endocrinopathies, and have significant deterioration of their bone health during pregnancy. If patients have got a history of hepatitis C or severe liver iron overload, they may get liver decompensation during pregnancy, and diabetic patients actually have a 4-fold risk of fetal anomaly and a 3-fold risk in perinatal mortality. So all of our patients have got various aspects of health issues related to all of these areas, and we need to ensure that we're looking at the patient in a 360-degree way and making sure that we're not just focusing on transfusion or iron chelation, and we're actually thinking about the whole patient. So thalassemia is a lifelong disorder. It starts with the initial diagnosis of thalassemia in a newborn baby. We initiate blood transfusions, and then we start chelation therapy once they've had more than 10 transfusions or the ferritin is raised. We then make adjustments with iron chelation and transfusion as that young child is growing into adulthood. And we start monitoring the iron burden, because monitoring of iron burden is actually one of the key things that we need to do to ensure we are preserving fertility in these patients. And then our patients grow up, and we continue to monitor both growth, pubertal development, endocrine function, compliance, and self-efficacy, i.e. how effective our patients are in looking after themselves and becoming expert patients. As patients enter adulthood, they get lots of challenges with life pressures, education, societal pressures, compliance with treatment, the desire to be the same as everybody else. And quite often patients will have periods where they stop doing chelation therapy because they don't want to be thinking about the burden of their disease. When patients develop stable relationships, quite often at that point, compliance improves, because many patients will then have an end goal of having a family. And we then need to make sure that we're making adjustments to both transfusion and iron chelation therapy to support conception and pregnancy in patients. And as patients get older, it's very important at that point that they develop work-life balance, and that we as clinician providers are able to ensure that there is flexibility within their transfusion schedules and adjustment of chelation so that it facilitates their lifestyle. And as patients get older, it's very important that we think about deteriorating health outcomes, complications from bone disease, and ensure that patients' quality of life is actually prioritized, because that has a major impact on health outcomes for patients going forwards. Today, we're going to really focus on these two areas. That's the development of stable relationships, improvement in compliance in preparation for proceeding on and having a family. So fertility preservation is really important. So what, when, and how do we do this? And what, when, and how should we actually be thinking about this? Well, in the transfusion-dependent patients, I think it's really important that we're thinking about this very, very early on. And it's about having conversations with patients and parents. And the main goal of all of these conversations is to facilitate normal pubertal development, because if children go through puberty naturally without any endocrine support, they are highly likely to retain fertility. And the goal should be that we monitor the iron burden very stringently, ensure the liver iron is kept below 7. I'm very strict with my patients. My target is below 5 for all of them. And we should be reducing the risk of alloimmunization with KEL and RH groups, particularly in the female patients, because these can cause additional complications during pregnancy. And we should be thinking about prevention of transfusion-transmitted infections, because these will also have an impact on the liver health of patients and the risk of complications during pregnancy. The non-transfusion dependent patients are normally fertile because they don't develop iron overload early on, but it is important to assess iron burden and endocrinopathies as per the non-transfusion dependent guidelines, and ensure that we have conceptually optimized them prior to a pregnancy. And for both NTDT and TDT patients, we really need to have conversations around avoidance of accidental pregnancies, particularly in fertile patients, the importance of partner testing and genetic counseling. We have had accidental pregnancies in our fertile patients because they talk to other patients and they have this concept that they are not fertile when they've gone through puberty naturally and are menstruating, and then they come in with positive pregnancy tests and you're saying, oh dear, what shall we do next? So patients who undergo or are about to undergo or are post-BMT, I think those patients have a very hard time, because our thalassemia major patients, if we manage them appropriately, they are all going to be fertile. If they've had a bone marrow transplant, they will have major challenges with fertility. Most of them will be infertile because of the conditioning regimes that they've received. So pre-transplant, we should be talking about fertility preservation. It should be discussed, the risk of infertility post-transplant. And in female patients, we should be talking about oocyte vitrification, embryo cryopreservation, and ovarian tissue cryopreservation. In male patients who are post-pubertal, we should 100% be doing semen cryopreservation for patients. The risk of infertility varies very widely in post-BMT patients. Most patients will be hypergonadotrophic, hypogonadism, in comparison to hypogonadism. And that means that their fertility challenges are very significant because we're looking at primary end organ damage for the ovaries and the testes. And they will not respond to ovulation induction or spermatogenesis induction. Good outcomes with fertility are seen in younger patients at the time of transplant, lower serum ferritin levels, patients who went into transplant when they were still pubertally quiescent. So going into transplant when you're going through puberty is a bad thing. Patients who are less iron overloaded are often ones which come out with better gonadal function, and reduced intensity conditioning definitely has a better gonadal function outcome. So optimization. So what do we need to do when we're optimizing patients? It's all about the conversations that you're having with your patients and their parents, and it needs to start very early on. As a young person enters into or is about to enter into a relationship, we need to talk to them about genetic counseling, make sure that we've tested the partner, that pre-implantation genetic diagnosis is available for high-risk couples, and things are appropriately managed in that level. Patients should be assessed for fertility complications. That includes tubal patency, sperm count, and hormone assessments to ensure that they both have good chances of conceiving naturally. Contraception, adequate contraception should be used until all aspects of health around pregnancy are optimized, and then we can tell patients to stop their contraception and try for conception. And clearly, psychological assessment is very important in patients and health lifestyle adjustment. Iron chelation, we normally recommend that patients continue with their iron chelation until they're ready for a pregnancy, which should be roughly around about 3 months to 6 weeks before planning a conception, at which point they should stop the oral iron chelation drugs and switch over to Desferal infusions. And in thalassemia major patients, we need to be talking to them about the increased transfusion requirement during pregnancy and a target hemoglobin of 100. And in the non-transfusion dependent patients, it's really important that they understand that they may end up needing blood transfusions during pregnancy, and that we are prepared for this potential transfusion by ensuring that we know what the patient's red cell phenotype is and their extended phenotype, just in case they're at increased risk of developing red cell alloimmunization. And when we transfuse patients, even preconceptually, they should be transfused with RH and KEL matched units, particularly the female patients, to reduce the risk of alloimmunization. So cardiac iron monitoring is really important. We should be aiming for a cardiac T2 star above 20 milliseconds in patients prior to pregnancy with a normal ejection fraction. Ferritin levels should be kept at very good levels, and liver iron targets should be below 7 milligrams per gram dry weight. I always use my MRI assessments. I don't worry about the ferritin results when I'm preparing patients for pregnancy. If you don't have access to MRI assessments, then you should be focusing on the ferritin and aiming for a ferritin of below 1500, close to 1000 in the majority of patients. But there are many things that affect the serum ferritin test, which is why having a MRI assessment to assess safety of pregnancy is actually really very important in this population. You should be looking for transfusion-transmitted infections, hepatitis B, C, HIV, making sure that hepatitis B levels are optimized. And you should offer HPV vaccination to non-immunized patients. These are UK recommendations, and they may vary within your countries and regions. From an endocrine preparation, a glucose tolerance test prior to pregnancy is very important, because you want to know if your patient has got abnormal glucose tolerance, because that would need to be optimized. You should, if you have a diabetic patient, be monitoring them using serum fructosamines, thyroid function assessment, bone density scans, vitamin D, and a proper endocrine workup is actually very important in advance of pregnancy. And medications prior to pregnancy that need to be adjusted, cessation of bisphosphonates. We always stop bisphosphonates at least 3 months, ideally 6 to 9 months prior to a pregnancy, because bisphosphonates hang around for a very long time and can affect skeletal growth in the baby. ACE inhibitors need to be adjusted or changed. We always start our pregnant patients who are planning pregnancy onto folic acid 5 milligrams daily to reduce the risk of neural tube defects. And we ensure that patients are taking desferrioxamine with some vitamin C to help improve the iron excretion. Splenectomized patients should be taking penicillin prophylaxis, and patients should be started on aspirin if they are not already taking aspirin. So the management of iron overload in females is actually really, really important, because good outcomes happen in well-planned pregnancies. And we have to remember that there's going to be 9 months of no iron chelation during that pregnancy. So we aim for a cardiac T2 star above 20 milliseconds prior to conception and a liver iron below 7, but ideally below 5 milligrams per gram dry weight. A spontaneous pregnancy on iron chelation is not an indication for termination of pregnancy due to exposure of chelator. The summary of product characteristics for the oral iron chelation say that there is a risk of fetal anomalies, but we have not seen this within humans at all. And there have been a significant number of pregnancies, accidental pregnancies, whilst patients are taking iron chelation, and those babies have been born healthy. So we make the recommendation to stop at least 6 weeks before a planned pregnancy. But if the pregnancy has happened and the patient is taking iron chelation, they're advised to stop as soon as the pregnancy test is positive, and talk to their doctor. Ovulation and IVF induction pregnancies are really very regimental, and patients should be on desferrioxamine during those cycles. They shouldn't be taking oral iron chelation because these are planned, appropriately managed pregnancies. In male patients, if they're naturally fertile and planning a pregnancy, we give them counseling and advise them to stop oral iron chelation and switch to Desferal at least 6 weeks before attempting a pregnancy. But again, spontaneous and accidental pregnancies are not an indication for termination due to chelator toxicity concerns. Patients undergoing spermatogenesis should continue with their existing oral regimes. And we should be aiming for really well-controlled iron levels, because the main times when I've seen spermatogenesis induction fail is when there is poorly controlled diabetes or poorly controlled iron burden. And I do tell my patients that sperm does not grow in sugar syrup. And it's really important that they optimize their iron chelation and their diabetes control before, whilst they're going through the spermatogenesis induction. We switch to Desferal around 3 months to 6 weeks before sperm banking and before planning a pregnancy. Management of endocrinopathies is really important, because this is where poor clinical outcomes really happen. Diabetes control needs to be really optimal, and we should be aiming for a fructosamine of around about 300 nanomoles per liter and blood glucose levels in the normal range most of the time for the patients, preconceptually, as well as during a pregnancy in the female patients. Thyroid function really needs to be optimized in hypothyroid patients. So conception, well, spermatogenesis induction is very challenging, and the aim is to avoid your patient ever needing spermatogenesis induction. If you do have patients who have needed assistance whilst they've gone through puberty, they've needed testosterone supplementation, they are definitely hypergonadal. Then doing a baseline assessment of their endocrine profile, including inhibin B and AMH, and semen analysis is very important. Hypergonadotrophic hypogonadism, that's high FSH, high LH, low testosterone, suggests testicular failure, and this will not respond to induction therapy. You need to be thinking about semen donation in those patients. It's very important to stop testosterone replacement in hypergonadal patients. In patients who are using gels, you can switch immediately to spermatogenesis induction therapy. For people who are receiving sustanon or libido injections, then the switch will happen at the time when the next testosterone injection is due. Patients can take a long time to respond, and I often end up telling my endocrinologist, no, carry on, no, carry on. It's going to be slow, carry on, because there's always a tendency to stop early, but that hasn't necessarily given the patient enough time on the therapeutics to actually respond. Most patients with thalassemia are going to need both FSH and HCG dual therapy to actually get an optimal response. So the protocol for induction that we use is we use HCG subcutaneously, 15,000 to 2,500 units, 2 or 3 times weekly. And we monitor the testosterone at 1 to 3 monthly intervals. And you will see very nicely the serum testosterone levels normalizing in these patients. The HCG dose needs to be adjusted to maintain those levels. If you're not getting a good enough response, then the lower dose, go up to the higher dose. You do need to check the estradiol levels. Some patients can get steroidogenesis and get breast tenderness, and there are therapeutics you can use to help manage that. Once normal values of testosterone are achieved, you need to do a semen analysis to just see if the patient's actually started producing sperm. The dose of HCG shouldn't be adjusted based on the semen analysis results. It needs to be adjusted based on the testosterone level results. If the patient's still azoospermic at 6 months after a normal testosterone level has been achieved, so they have to have had a normal testosterone level for at least 6 months, then you should be introducing FSH therapy, which is usually with a drug called menotropin, and that should be started initially at 75 international units, 3 times weekly subcutaneously, and then you can make adjustments in the dose. And you should consider FSH and HMG at the start of HCG therapy in patients. So you should consider actually going in with combination therapy at the start in patients who've had incomplete or absent puberty. So they've got very small testicular volume, they've not completed puberty properly, then using dual therapy is probably the right thing to do. And semen analysis should be done every 3 months. You should continue treatment in azoospermic patients for 24 months after the start of combined therapy. But if they haven't responded by then you can stop this therapy unless they're going to go for microtease, okay? So unless they're going for an ICSI type procedure, you should at that point, 24 months after combination therapy is started, you should be considering stopping it because they're going to fail to respond. In female patients, it's essential that you do a full fertility workup prior to initiation of gonadotropin therapy. And we use the NICE guidelines for management of conception in females. So the male and the female partner need to be thoroughly tested. And in the females, we do an estradiol, FSH, LH, and a progesterone assay. These can be done at any time in hypergonadal females. You do not need to do it according to day 2 and 5 or according to day 14. You just do it at any time because these patients are actually hypergonadal. Patients with hypergonadotrophic hypergonadism are, again, unlikely to respond because this is primary ovarian failure. And then you need to be thinking about egg donation as the management strategy in these patients. And we do need to do a transvaginal ultrasound in patients to look at ovarian volumes, look at the follicle count, and assess uterine morphology. An ovarian reserve, so the AMH test can actually appear very disappointing because these patients have not had their ovaries stimulated. So having a low AMH is not a reason to not go ahead with ovulation induction. Once you start stimulating these patients, their AMH levels will improve, and actually they will, because the ovary hasn't been stimulated, they will start to make follicles and they will do better. So the AMH level should be done, but you should not base your decisions on what the AMH level actually shows. All patients should have a tubal patency test to rule out tubal disease, because that's going to make your decision about, do you go for ovulation induction and natural conception, or do you go with ovulation induction IVF? So it's important to do the high COSI and make sure that you're aware of what the situation is with tubal patency. So this is an example of a workup for patients during ovulation induction. And this is basically the Whittington Hospital protocol. We will do ovulation induction if the endometrium is less than 4 millimeters and there's no follicles more than 10 millimeters. We start HMG, which is menopause, at 75 international units daily. At day 10 to 12 post-initiation of stimulation, we assess the patient. If there's no follicles, we continue on the same dose for a further 5 days, but we can go up to 21 days in our patients because they're often slow to respond, especially with the initial cycles. Day 10 to 21, we again reassess the follicles and make a decision about using a trigger injection. If the patient has got less than 2 follicles that are more than 14 millimeters, then we will give the trigger injection of 5,000 international units of HCG or Ovitral. And day 7, after the trigger injection, we will monitor the serum progesterone levels to assess what the response is. And day 14 to 18, after the trigger injection, we'll be starting to measure the HCG levels to see if the patient is pregnant or not. If the patient's not pregnant, then we, on day 2 of the withdrawal bleed, will make a decision to initiate the next cycle of ovulation induction. And if there's no follicular development achieved, or 6 cycles of successful ovulation but no pregnancy, then we will at that point have an MDT discussion about either moving to IVF or going to egg donation if there's no follicular development, because that tells you that the ovaries are not going to respond. Question I get asked a lot about is thromboprophylaxis during induction. So thromboprophylaxis is not indicated in patients without any known risk factors who are undergoing IVF therapy. In patients who've had a diagnosis of ovarian hyperstimulation, then they should definitely be given thromboprophylaxis, and that is a very strong recommendation. Thromboprophylaxis should be continued until resolution of ovarian hyperstimulation, or at least until week 12 of a successful pregnancy. In the presence of other risk factors, thromboprophylaxis should be continued according to standard guidelines. Thromboprophylaxis can be stopped 4 weeks after resolution of ovarian hyperstimulation if the patient is not pregnant. And a decision around thromboprophylaxis during IVF stimulation and pregnancy should be made by the hematologist who's referring the patient for IVF based on the patient's history and other risk factors. And in patients where thromboprophylaxis is indicated during pregnancy, this should actually be started at the time of FSH and HMG stimulation. And that's, again, a very strong recommendation. So management of pregnancy. So patients who've successfully reversed myocardial iron overload and don't have cardiac iron load at the time of pregnancy should actually sail through the pregnancy, but you need to be aware that they may develop arrhythmias during the pregnancy, and that's because of myocardial scarring that's happened from excess iron overload that may have happened many years ago. These are high-risk pregnancies, and we need to make sure that there's a good multidisciplinary team around the patient. This includes an obstetrician, a midwife, a hematologist, as well as specialist input from cardiologists and diabetes if needed. And in the UK, all of the antenatal care should follow the NICE guidelines, and pregnant patients with thalassemia need to be reviewed every 4 weeks until 28 weeks of pregnancy, and then fortnightly thereafter. So the booking appointment in the UK generally happens pretty early on, somewhere around about 6 to 12 weeks of gestation. There's usually a whole lot of things that need to happen at that point. So discussion with the patient around pregnancy risks, prenatal diagnosis if they haven't had partner testing, so you can go for chorionic villus sampling at that point. Refer to the diabetes team, ensure that the endocrine, cardiac, and all the other workup has been done. If they've not had a cardiac or a liver T2 star and an ejection fraction done in 12 months before conception, then you need to organize an MRI assessment for heart and liver iron burden, and a echocardiograph if your equipment doesn't do a left ventricular ejection fraction. And you should be looking at an abdominal ultrasound in your pregnant patients with non-transfusion dependent patients to assess for spleen size and liver. Baseline blood tests should be done at the time of conception, at the time of the booking visit, and you need to be monitoring and thinking about venous thromboembolism risk. The UK guidelines, based on a significant randomized control trial, basically now recommend that you prescribe 75 to 150 milligrams of aspirin daily in the evening and folic acid 5 milligrams daily if the patient is not already taking it. And the 75 to 150 milligrams of aspirin is to improve the, reduce the risk of thrombosis and reduce the risk of preeclampsia in these pregnant patients. You should discuss vaccination in all of the patients and penicillin prophylaxis in those who are not taking it. And also they should be having the first trimester ultrasound scan to confirm a viable pregnancy. So at around about 16 weeks, the patient should have a glucose tolerance test if they've got a high BMI or if they've previously had an abnormal glucose tolerance test. In all of our patients, we do a glucose tolerance test annually. So if they've not had one within the last 12 months, they will definitely have one at that time. And they have the standard 20-week MDT discussion. At around 20 weeks, this is when you need to be thinking about your cardiac iron-loaded patients. If they've got cardiac iron loading, you need to be starting iron chelation in these patients. So if the T2 star is less than 10, start with desferrioxamine. We give 20 milligrams per kilogram per day on 4 to 5 days a week, and this is managed by the hematologists. If the cardiac T2 star is between 10 and 20, we make an individualized risk assessment and we look at the ejection fraction, and then we think about, are we going to give them chelation or not? Most of the patients will be offered chelation, particularly if the T2 star is below 15. If it's between 15 and 18, we often don't do anything. If the T2 star is above 20, there's no indication for iron chelation during pregnancy at that point. We do a routine review at 24 weeks, and at 26 to 28 weeks, non-diabetic patients will have another glucose tolerance test done at that time. In the third trimester, we really focus on fetal growth and development. So the mother will be having ultrasound scans to look for fetal growth and development every 4 weeks, because IUGR is a well-recognized problem in thalassemia pregnancies. But because the patients are already taking aspirin and being monitored very rigorously, we, with optimization of hemoglobin levels, we've not seen in my practice small babies. Specialist cardiac review should happen at 28 weeks. And at that point, they need to make a decision about, is the mother medically fit to deliver a normal vaginal delivery, or should she be given a cesarean section? Sorry. We'll also be at this point talking about VT thromboprophylaxis in patients who are not already on thromboprophylaxis with low molecular weight heparin. And then routine reviews will happen at 30, 34 weeks with ultrasound scans, and we'll make a management plan for delivery with the mother and review the use of aspirin and continuation, discuss the timing and the mode of delivery, how we're going to manage the delivery, and what should be happening around that particular time. This conversation happens at around about 36 weeks of pregnancy, and then patients follow the standard schedule for review. So with transfusions, in the thalassemia major patients, we're going to be aiming to keep the hemoglobin above 100. And that allows good oxygenation of the fetus and really does, in my opinion, help support better outcomes in patients. In the non-transfusion dependent patients who've got a maternal fetal complication, we will transfuse those patients and we will aim for a post-transfusion hemoglobin of 120, which basically means a pre-transfusion hemoglobin of around about 100 in the non-transfusion dependent patients. And this will also happen if there's evidence of fetal IUGR. In the NTDT non-transfused patients who have managed to go through pregnancy without needing blood transfusions, baby's growth and development is looking completely fine, we will avoid transfusion and we will consider a 1 to 2 unit top up at around 37 to 38 weeks of pregnancy if the hemoglobin is less than 80 and the mother is symptomatic. Baby's growing fine, we often will hold fire. We'll have 2 units of blood cross-matched for delivery so that if mum does need an emergency transfusion at the time of delivery, we're able to manage that. And postnatally, we will transfuse as appropriate based on obstetric postpartum issues. So thromboprophylaxis during pregnancy, the VTE risk is raised in thalassemia patients and more so in patients who are splenectomized with beta non-transfusion dependent thalassemia or those who've got a significant thrombocytosis. Aspirin reduces the risk of thromboembolism in splenectomized patients and is recommended in all patients who've got raised platelet counts, particularly above 600. Patients with prior history of thrombosis need to be managed as per the RCOG green top guidelines for patients with patients who are pregnant. And we follow those guidelines really very rigorously. The prothrombotic state in patients with alpha non-transfusion dependent thalassemia, so that's basically HBH disease, is less clearly defined. And all of these patients should basically have an individualized risk assessment and a decision based on that individualized risk assessment. And venous thromboembolism risk assessment needs to take place at fixed time points at the initial booking visit, at which point you decide, do you do thromboprophylaxis during the whole of the pregnancy, or do you just do it in the last trimester? At 28 weeks of gestation, again, a reassessment on the thromboprophylaxis risk. And during any admission the patient has, including delivery and postpartum, using a recognized risk assessment tool. So we recommend patients with thalassemia who are splenectomized, this is TDT and NTDT, or who have a platelet count above 600 should be offered low molecular weight thromboprophylaxis in addition to low dose aspirin between 75 and 150 milligrams per day. And this is a level 1A recommendation with very high quality evidence behind it. Consider low molecular weight heparin from 28 weeks to 6 weeks postpartum or throughout pregnancy if there are additional risk factors. And all pregnant patients with thalassemia require low molecular weight heparin during hospital admissions. So with regards to chelation, I've already covered this for the cardiac iron-loaded patients. So severe cardiac iron-loaded patients, there's no question. You give them Desfral from around 20 to 24 weeks of gestation, and it's low dose, 20 milligrams per kilogram per day on roughly 5 days a week. In patients who've got evidence of cardiac decompensation or a falling ejection fraction or evidence of heart failure or a cardiac arrhythmia, there's no discussion. You absolutely have to go to IV Desfral 24 hours a day, 24/7 at a dose of 40 to 50 milligrams per kilogram per day, because if the mother doesn't survive, there's no point with the pregnancy. And so you're doing this as a life-saving intervention in someone with obvious cardiac risk. In severe hepatic iron loading patients, you need to be thinking about low dose iron chelation from 20 weeks of gestation based on an MDT opinion on how severe the iron burden is and what the risk of that patient is of developing liver decompensation, endocrine complications, or cardiac toxicity. And quite often I will start iron chelation in the hepatic iron-loaded patients somewhere between 24 and 28 weeks of gestation, but at a low dose, generally about 2 grams 2,000 milligrams, or a dose of around 20 milligrams per kilogram per day. But I don't normally go above 2,000 milligrams per day. During the delivery, we follow national guidelines, and there's very clear, nice recommendations for the delivery. And TDT patients will have had 9 months of no iron chelation, and we know that patients can get a heart failure or cardiac arrhythmias due to the stresses of labor. And so peripartum chelation is indicated in TDT patients to reduce the amount of toxic non-transferrin bound iron and reduce the risk of free radical damage and cardiac arrhythmia during labor. So when patients come in for delivery, it's important that the midwife, obstetrician, anaesthetist are all aware that the patient has thalassemia. Red cell antibodies and making sure that cross-match blood is available is really important. In the transfusion-dependent patients, we start IV Desfral 2 grams over 24 hours, and this starts when the woman arrives for her delivery, whether it's a cesarean or whether she's in active labor. And that will continue throughout labor and in the postpartum period. And we do continuous intrapartum electronic fetal monitoring. And thalassemia on its own is not an indication for cesarean. Cephalopelvic disproportion, other risk factors should guide the decision for a cesarean section, but having thalassemia on its own is not the main indication. We ensure there's active management of the 3rd stage of labor to reduce blood loss. And patients continue Desfral, IV or subcut, whilst they're in hospital. If they're breastfeeding, the discharge is with a recommendation to build up to 40 milligrams per kilogram per day of Desfral by the 4th to 6th week postpartum. So we ask them to basically increase their infusers on a daily basis once they go home. If the patient's not breastfeeding, put them back on their pre-pregnancy iron chelation regime, but make sure you're putting them back on optimal doses. And thromboprophylaxis for 6 weeks postpartum for those who've delivered by cesarean section, people who are post-splenectomy with a high platelet count, or who've had a previous VTE event, or are otherwise considered high risk. NTDT patients, they should again be provided VTE prophylaxis as per their risk category. And you should be planning to assess their serum ferritin and MRI iron burden, particularly if they've been transfused. And it's an individualized decision to optimize iron burden. If the liver iron is more than 5 milligrams per gram dry weight, you should talk to them about iron chelation, and they should resume their preconception general management regime after delivery of the baby. For breastfeeding, we actively encourage breastfeeding, and we reassure the patients that Desfral does not affect the baby if the mother is breastfeeding. The oral iron chelators do, and so if mum is breastfeeding, she should not have oral iron chelation. So if she's not breastfeeding, we switch them to their oral regime. If they're breastfeeding, she needs to stay on Desfral for as long as she's breastfeeding. We reassess at 3 months for myocardial iron loading in all of the patients who've completed pregnancy. If a woman is breastfeeding and she's struggling, you can consider low-dose HRT with estradiol, because that really helps hypogonadal patients with the breastfeeding side of things. And contraception in all its forms is entirely possible and feasible for patients to take, and we should actively encourage them to take that. And these are some of our babies over the last 10, 15 years. Most of these babies are now, much, much bigger than they were. It's such a joy to be able to see patients having babies and, really becoming family units with their partners. And this is the writing committee, Dr. Amakai Mensah, Dr. Mamta Garg, Sarah Nicole, Karen Anthony, our spermatogenesis expert, and Mr. Gideon Lieberman, who is our female conception expert, and Dr. Shivan Pancham, who was the BCSH rep during the guideline publication. So thank you very much for listening. And I shall stop screen sharing.
Thank you, Dr. Faruk Shah, for that fantastic lecture. It was a brilliant lecture. You covered almost everything from top to bottom, how to manage thalassemia in pregnancy. That was great. And now we
Thank
have colleagues who will bother you with question answer session. So we'll start with Dr. Omkar Khankar. Your question, please.
Yeah, hi. Thanks, Amit, for giving me the opportunity immediately after the lecture because I'm still getting over it. It was a wonderful lecture. I have one question. Are there any specific indications where you would advocate not having A, for a male thalassemia patient who is a transfusion dependent, and B, for a female thalassemia patient who is transfusion dependent?
So I lost your voice in there. So I would, can you just repeat the question?
Yeah, are there, can you enumerate the indications where you would advocate not having conception and pregnancy to your transfusion dependent thal patient?
That's a really good question. So who would I say, no, you can't have a baby? There's very few patients that I would say, no, you can't have a baby. And I, genuinely, I would, even with those patients who are hypergonadotrophic hypergonadism, I would talk to them about sperm donation pregnancies and egg donation pregnancies. And we've got a number of thal major couples where both the male and the female are thal major, and they have had pregnancies using egg donation or sperm donation. So it's very rare for me to say, no, you can't have a baby. They have to have psychological assessment. Clearly, if someone is completely mad, then the answer is no way. But otherwise, I think it's within everyone's right to be given the opportunity. I've got a 40-year-old, well, she's 41 years old, thal major, with very heavy iron overload. And I've counseled her around pregnancy, explained to her what the risks are. She's willing to give it a go. And I've said very clearly to her that she's going to need chelation from 20 weeks of gestation if she does successfully conceive. So it's worth giving everyone a go. We've had 42-year-olds get pregnant with ovulation induction.
Thanks a lot.
Thank you, Dr. Omkar. Dr. Anita Radhakrishnan, ma'am, your question, please.
Hi, Dr. Shah, it was a wonderful discussion. I think I caught you saying that your patients are now grandparents. So congratulations to you. Wonderful the way you've been managing your patients. I think we are a very, we have patients who have become parents, but not yet where you are. So my question to you is, so I look after children basically. So when we have adolescents who are very poorly chelated or young adults, we often see, who are heading towards primary ovarian failure, what all steps would you take at that scenario? Like increasing chelation and adhering to a good transfusion regimen is something that we tell them. But would you advise ovarian cryopreservation like in a BMT setting in those kind of patients also? Would you preemptively do cryopreservation in such a scenario?
So in our setting, it's very rare for us to see people having primary ovarian failure. What we will always do in the patients as they're moving through puberty is we're going to do pubertal induction. So that will be with either very low dose testosterone or it will be with the estrogen preparations to just induce them into puberty. If they do induce into puberty, then generally, most of those patients, the boys in particular, if you're monitoring the testicular size and the testicular size is growing normally, those boys are going to be fertile. So that's a good thing with low dose testosterone replacement therapy as they move into puberty, because sometimes they just need a bit of induction. In the girls, we will induce puberty. It's really important to remember that iron overload can cause primary ovarian failure, but you really have to have very, very, very severe iron for a very long time to get genuine primary ovarian failure. And in those patients, generally, when we stimulate them as part of a ovulation induction protocol, they do really well. And they actually do move into the ability to ovulate very easily at that point. They do, after ovulation induction, need to go back on HRT because they've basically got quiescent ovaries, but you will get them through ovulation induction without any problem. So in the Thal majors, I haven't referred any of our patients for ovarian tissue cryopreservation unless they're going for BMT or oocyte vitrification kind of processes at all, because it's just not really been indicated. They respond well when you stimulate them.
Yes, okay. Thank you.
Thank you, Dr. Nita ma'am. Dr. Narendra Chaudhary, your question, please.
Yeah, thank you, Dr. Shah, for wonderful lecture. My question is related to one personal experience of one thalassemic parents. One child with thalassemia had mother beta thalassemia minor, but father was normal based on HbA2 and CBC. So it was, maybe it is silent beta mutation. I don't know what happened to that, whether any genetic testing was done or not. But what is your protocol? Do you see for mutation in all parents to rule out every possibility of silent beta mutation so that this situation doesn't come later on? And sometimes parents blame you checked everything and you told that it is I'm normal, but how come my son or daughter is having thalassemia major now? So what is your experience of having silent beta mutation and how do you deal with it?
We're in a region where silent beta is common. It's very difficult. And so the CAP1 mutation, I mean, I have a family where exactly your story happened. The mother almost got divorced. We did do genetic testing. We confirmed father is CAP1 and the baby is CAP1 as well. And they did do a HPA, they did do a HPLC premaritally. So, these situations do happen. Now, if we're doing premarital genetic screening, we don't normally do beta globin genotyping for these patients. And it's just a risk that you have to basically, yeah. But I would definitely, if you do end up with a Thal major baby and a carrier mother and a normal father, I would definitely send the father's blood for silent beta mutations along with the babies, because obviously the paternity issues become a real, from a marital point of view, they become a real issue, don't they?
Okay, thank you.
Thank you. Dr. Ashok Mishra, your question, please.
Thank you, Dr. Shah, for a beautiful lecture. My question is about the chelation therapy. Though I read that the oral chelation therapy like deferoxam is contraindicated in pregnancy, but also about deferoxam, where there is some fetal toxicity was studied in animal models, fetotoxicity and some skeleton issues. So, do you observe it in any of your patients, particularly who were treated during pregnancy?
Yeah, so this is one of the reasons why we're using a low dose of 20 milligrams per kilogram in the pregnant patients that need iron chelation, because if you don't iron chelate the pregnant woman who's got cardiac iron loading, there's a 50% chance of her decompensating within 6 months if she's got a T2 star less than 10. So you have to, and these patients have gone, they've gone and got pregnant. So quite often it's a spontaneous pregnancy, because you would never do that in a ovulation induction or an IVF pregnancy. You would insist that the heart was normal. So these spontaneous pregnancies that have happened in these cardiac iron-loaded patients, you have no choice. You've just put them onto iron chelation. But we use a very low dose, so 20 milligrams per kilogram per day. We've been using it for many years, and I've not seen any skeletal abnormalities in the babies or any other problems. And we generally will start at 20 to 24 weeks post, at 20 to 24 weeks within the pregnancy. So that reduces some of the risk as well. I think with the heart failure patients, it's just you just don't have a choice. You've just got to accept that there is going to be a risk. She's either not going to live long enough to deliver the baby, or the baby may have a problem.
Thank you very much, ma'am.
We have some questions, couple of questions from the audience. Doctor, M value wants to know that if a patient tells minor, what is the optimal hemoglobin would like to maintain during pregnancy?
So, Dr. Amit, your voice isn't coming through clearly for me.
Are you able to hear me now? Yeah, now able to hear me?
Yes, I can hear you now.
Okay. So, question from Dr. M. Velu. In case of Thel minor, what would be the optimal hemoglobin value which you will maintain during pregnancy?
Really good question. Depending on some of the beta thalassemia minor mutations, some of the patients can become very anemic during pregnancy. And unfortunately, some of the thal minor women do end up needing to have intermittent transfusions during pregnancy. I think if there's significant maternal anemia during pregnancy, whether it's an alpha or a beta minor, a carrier patient, really important to optimize B12 iron and folate stores first, and then assess the baby's growth and development. So, look for fetal IUGR, see how things are going. If mother is tolerating the anemia and she is optimal with iron, B12, and folate, then nothing needs to be done. And I would probably allow the hemoglobin to stay around about 80. And treat her a bit like an NTDT in that sense. If there is evidence of fetal IUGR and you've got normal B12 folate iron levels, then I think that's a complex decision about do you transfuse, not transfuse, bearing in mind all of the risks that go with transfusion. I think the majority of the beta thalassemia carrier patients, and they shouldn't need transfusion, but you will have some who do occasionally need transfusion. I would definitely send off for genetic analysis to see what mutation the patient has. It could be that they are a beta thalassemia trait with a triplicated alpha, which makes them into an intermediate. So I would definitely do genetic analysis either during the pregnancy or post-pregnancy, just to see where the patient sits. But at the end of the day, pregnancy is a really critical time for a woman. If you need to always optimize the hematinics and then go in with transfusion if you've got no choice, especially if there is evidence of IUGR.
Thank you. So if the patient has got serum ferritin normal and thalassemia minor patient, do you still need to prescribe iron supplement in such patients?
Well, yes, it depends on what you call normal as a ferritin, right? So the normal range for ferritin in females is 15 to 150. And my personal view is that the ferritin should be between 50 and 100 in a thalassemia trait woman who is undergoing a pregnancy. The baby sucks iron out of the mother because it's got to make its own blood. And so I would definitely recommend iron supplementation to thalassemia carrier women if the ferritin is below 50. Because baby's going to be taking that. And you need to be looking at the transferrin saturation as well, because the ferritin may be up because of inflammation and other things that are going on. And you need to be aiming for a transferrin saturation between 25 and 30% in a pregnant woman. And you should be measuring the transferrin saturation when the patient has not taken any iron replacement therapy for 24 hours, okay? So that's basically the kind of rules you need to set for monitoring thalassemia carriers during pregnancy and making sure you're using all of the tools that you've got available to make sure you're making the right decision.
Thank you. Another question from Dr. Sway. If the patient undergoes IVF, that is in vivo fertilization versus in vitro fertilization, what is the difference in the management between the two patients?
None.
So it's almost the same.
Yeah.
And another question from Dr. Myat Mallesway. Do you have any experience in thalassemia patient becoming hypopituitarism due to complication? And if so, how do you manage such patients?
So hypopit, they're basically talking about a low FSH, low LH kind of problems, I assume. So heavily iron overloaded patients will become hypopituitaric and will then fail to go into puberty. It's unusual to see them developing hypopituitarism after they've completed puberty. So there seems to be some kind of, they seem to be all right after that. So generally, you would replace what they're missing. So in a thal major who's hypopituitaric, you have to replace estrogen or testosterone, thyroid, if they're hypothyroid, and go on that basis. So that's basically what I would say is what we would end up doing for those patients.
Thank you. Another similar question from Dr. Myat Malliswe again, that in pregnancy, if the female experiences problem during transfusion because of development of alloantibody formation, how do you manage such patients?
I hate alloantibodies. It's very, very, very difficult. Okay, so it's a preventable problem. It happens because we're transfusing, but we're not appropriately providing the right blood for those patients. So to avoid it happening in the first place is what the Holy Grail is. We should be aiming to avoid in the first place. So all females should be getting RH and KEL compatible blood transfusions from an early age. It should be for everyone, but in particular, it's important for females. If you've got a pregnant lady, and I've had a few of these, and they do give you a good few gray hairs when you're doing this. If you have a lady who has got an RH alloantibody or a KEL antibody or any of the other significant antibodies, you need, but these are the main ones. So the RH antibodies cause hemolytic disease in mothers, and KEL can cause significant anemia in mothers. So what we do is we monitor the antibody titers for the mothers during the pregnancy. If the antibody titer is continuously rising, we ensure that we're monitoring the baby for evidence of fetal anemia or HDN, and that is done by serial ultrasound scans as well as fetal blood sampling. But you can also test the father to see if the father carries the relevant antigen. Okay, so we have had patients where the antibody titers have been going up. And when we tested the father is antigen negative. We've tested the baby's fetal anemia levels, fetal hemoglobin levels. Hemoglobin is okay. And we've reassured ourselves that the antibody titer is going up, but actually baby is doing fine. And we then continue to just monitor baby. If there is evidence of fetal anemia, you have to treat it, which means you do either a fetal transfusion or an exchange transfusion, depending on what the obstetric recommendations are in those situations. And it can make pregnancy very difficult for the mothers, in addition to all the other problems that they have to deal with around iron overload and all of the other complications that they may have.
Thank you. Another question from Dr. S.K. Sharma. This level of monitoring of fructosamine every fortnightly is very difficult and not liked by many patients in India actually. So, and plus the HbF level also interferes with your HbA1c management. Any midway solution for this?
So fructosamine we do every 4 weeks, not every 2 weeks. The midway solution is to make sure your patient is testing their blood sugar regularly if they're diabetic, okay? So you get all of these implantable devices nowadays, and you can use that to assess your patient if need be. But the HbA1c is very unreliable. You will run into problems with diabetes control if you're relying on the HbA1c. Fructosamine can also be unreliable in patients who have got a high bilirubin level. So what we tend to do is we tend to use the patient's self-testing blood glucose results as a much more stringent kind of a guide, especially if they've got an implantable blood sugar monitor like, Diomed or something like that. It just makes life a lot easier, and you can provide much tighter control if you're using the continuous blood sugar monitoring.
Thank you. Another question from Dr. Myat Mallesway. Your easy approach for managing the thalassemia in pregnancy in a resource limiting setting like us, where MRI, when MRI is not available or your glucose tolerance test is not available. So how would you manage thalassemia in pregnancy in a resource poor settings?
Yeah, so glucose tolerance anyone can do. It's just giving them 75 grams of glucose and checking the blood sugar fasting and then 2 hours later. So you can do that, and it's not really a resource intensive thing to do. From an iron point of view, I think it's very difficult, because MRIs are very, very useful. So get an echocardiograph, make sure the ejection fraction is okay. Remember that the ejection fraction, when it starts to go down, it means your patient already had too much iron loading and they've got a T2 star of less than 8, because they won't go into heart failure unless it is less than 8. So ejection fraction is very useful. Ferritin you can do, and you can look at the patient. If the liver function tests are normal, there's no evidence of skin iron deposition, their ferritin is well controlled, then you can make a reasonable judgment that they should be okay to get through a pregnancy, because skin iron deposition occurs when the liver iron's above 25. If the echo is normal, it means the T2 star is above 8. So you can use these two parameters, which are reasonably easily available, to kind of make a judgment call. But where possible, you should be aiming to get if you have access to it, you should be aiming to get the standard tests.
Thank you. And the last question from one of the thalassemic patients. He wants to conceive. Basically, he's a male patient, thalassemia male patient, wants to conceive. Right now, he's on thalidomide, 100 milligram once daily. Serum ferritin level is about 500. On deferaz-xerox, iron coated tablets, the coated tablets, that is 360 milligram. Right now, the weight is 46 kg, hemoglobin maintaining at 10 grams. How should I approach, or how should he approach?
Yeah, so the approach will be to look at what the risk of genotoxicity is with thalidomide, and that would be the main drug I would be worried about. I'm not particularly worried about the iron chelation drugs. Those can stop 6 weeks before. So depending on when it's safe, you would need to stop the thalidomide, probably go on to a transfusion regime, or just wait for the hemoglobin to settle and then see how he manages with that. And then he can try and conceive. With the hydroxyurea, we have got a lot of experience of sickle cell patients getting their partners pregnant whilst taking hydroxyurea. Ideally, you should stop hydroxyurea as well. But there are a number of, a huge number of accidental male pregnancies have happened on hydroxyurea, and the babies have been born fine. So again, if you're looking at the drugs that you're stressed about, I'm less stressed about iron chelation, less stressed about hydroxyurea. I am very anxious about thalidomide. So I would stop that definitely as per the SPC recommendations before planning a pregnancy. That's the only thing I would say that this patient needs to really be concerned about.
Thank you. Another question from Dr. Shyam. Any role of erythropoietin in thalassemia minor presenting with severe anemia during pregnancy after optimization her iron, B12 and folic acid levels?
You could potentially use erythropoietin if you wanted to avoid transfusion. I've got no experience of it, but I don't see any reason why it wouldn't work.
Thank you. Dr. Yimon Tent, your question.
Madam, thank you for the excellent talk. You mentioned about aspirin inhibitor iron organ overload. My question is, any periodic catalog level as a non-pregnant patient, and any experience or iron chelation?
So I would use the old guidelines all recommended a ferritin level of 1,000 or below for pregnancy. The problem is that the ferritin is not an easy test to interpret because it's affected by so many things, including the iron chelation drug. But I would say that if the ferritin is below 1500, you're probably okay to go ahead with iron chelation, to go ahead with a pregnancy in that patient. I do allow pregnancies in people with higher ferritins, but I have a MRI result available to me, so I know that the iron's well controlled. So I would use a ferritin of between 1000 and 1500.
So oral iron chelation, were you always contraindicated?
In pregnancy, yes, unless, so certainly in the first trimester, it's always contraindicated. And generally, the earliest you should consider starting, and it is the very earliest, is around about 20 weeks. If you are going to start it for whatever reason, then 24 to 28 weeks is probably safer from a fetal point of view. The reason you'll go in at 20 weeks is if you're worried about maternal decompensation from cardiac iron.
Yes. Second question is thromboprophylaxis in post-prenatal patient, madam. Where you give aspirin or heparin or both in such patient?
Yeah, so it depends. So we recommend aspirin for all the patients who are post-splenectomy with a platelet count above 600. And depending on the mode of delivery, they should be given low molecular weight heparin as well. In the non-transfusion dependent patients, the NTDTs, we recommend both low molecular weight heparin and aspirin in the splenectomized patients because they're highly thrombotic, and regardless of the mode of delivery, they're going to be at an increased risk of having a thrombotic event.
Yes. Thank you so much.
Thank you, Dr. Montent. I've finished all the questions from the audience. Any discussion want to ask any other question? So there are no more raising signs. Well, thank you so much, Dr. Farooq Shah, for that fantastic and lovely lecture. And what a recommendation, and you touched everything from top to bottom regarding the management of thalassemia and pregnancy. And I think from tomorrow onwards, you'll be a better dealer for all these patients with all your recommendations as well as the management aspects in thalassemia and pregnancy. Thank you so much for being with us today. And I also thank all our discussants as well as audience to join us today, and meet you next week with another beautiful webinars. And I hand over to Sumit Kumar Madan for the final word of thanks.
Thank you, Dr. Farooq Shah, for sparing your valuable time for this lecture. It was an exceptional presentation followed by a highly interactive discussion. Your insights and expertise made a significant impact, and we are grateful for this. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest for the day, Dr. Sujata Sharma, all the discussants and participants who have joined us for this webinar. Thank you to our Dr. Amit for navigating the entire program so wonderfully and proficiently. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square Team. Thank you so much, everybody, and have a wonderful Sunday.
Thank you.
Bye-bye.
Bye.